Hi, this is Dr. Devaji Rao, a surgeon from Chennai, India. Apart from being a surgeon, I've been a medical author and written books in surgery. This shows the books published by the JP Medical Publishers, New Delhi, India, and the Annie Books, New Delhi, India. These are the recent publications. The first book, Snapshots in Gastroenterology, has been published by the JP, and the other two books, The Clinical Manual of Surgery and Essentials of Surgery for Dental Students, are published by the Elsevier, India. I am now going to talk to you on gallstones, otherwise called cholelithiasis. Cholelithiasis is defined as presence of stones in the gallbladder. Gallstones are congregations of cholesterol, bilirubin, and bile salts. The prevalence varies in different regions of the same country and different parts of the world. Gallstones are prevalent in all parts of the world, and in India, it is about 10 to 22%. In India, the gallstones are prevalent more in the north than the south, about 7 times more commonly than the South India. The reasons probably being the dietary factors and the geographical factors.
The extrahepatic bile ducts consist of the left and the right hepatic ducts, which join to form the common hepatic duct, which is joined by the cystic duct to form the common bile duct. The common bile duct is about 7 to 10 centimeters in length and runs in the free edge of the lesser omentum and runs behind the first part of the duodenum to open in the medial aspect of the second part of the duodenum through a thick coat of circular muscle, the sphincter aorti, at the ampulla of Vater. The CBD is joined at its terminal part by the pancreatic duct to form a common opening. The gallbladder is a pear-shaped organ about 7 to 10 centimeters long with a capacity of about 50 ml. When distended, can expand up to 300 ml. It is situated at the undersurface of the liver at its fossa, which divides the liver into left and right lobes. The gallbladder is divided into fundus, body, infundibulum, and neck. The fundus is the rounded blind end of the organ, which contains most of the smooth muscle and elastic tissue. The body via the infundibulum, that is the Hartmann's pouch, tapers like a funnel to join the cystic duct. The gallbladder is lined by a single, highly folded, tall columnar epithelium containing cholesterol and fat lobules. The gallbladder differs from the GI tract that it lacks the muscularis mucosa and submucosa. The bile contains three lipid species: cholesterol, phospholipids as lecithin, bile acids. Bilirubin and protein are also present in small quantities. The pathogenesis of cholelithiasis. Cholesterol is not water soluble, that is, it is hydrophobic, whereas the bile salts and lecithin are water soluble. The biliary cholesterol is carried in a stable form as particles called as micelles made up of lecithin and bile salts. When the capacity of lecithin and bile salts to keep the cholesterol in the soluble form is exceeded, supersaturation of bile occurs, and also there is excess of cholesterol secretion into the bile. The lipid cholesterol transforms into solid cholesterol crystals, a process called nucleation. The nucleating factor in the gallbladder is the mucus. Hypotonicity and hypomotility of gallbladder produces stasis, which alters the bile composition and accelerates crystallization. The mixture of gallbladder mucus and small cholesterol or calcium bilirubinate crystals is formed in the redundant gallbladder called biliary sludge. Conglomeration of components of the biliary sludge result in macroscopic stones. 75% of the patients with gallstones have cholesterol predominant stones, which are called cholesterol stones. The remainder contain pigment stones. Here you see the diagrammatic representation of the pathogenesis of cholelithiasis. This table shows the various characteristics of gallstones. The first stone is a cholesterol stone. A pure cholesterol stone is uncommon. The pure cholesterol stone appears as a single large stone with smooth surface and is yellow in color. It is radiolucent. This occurs due to the supersaturation of cholesterol in the bile. The second variety, which is the most common variety, is the mixed stones. Cholesterol plus variable amounts of bile salts and calcium are present in these stones. And these mixed stones are multiple, variable in size. They may be hard and faceted or irregular, mulberry shaped and soft. The stones appear whitish yellow and green to black in color. The third variety is the pigment stones, which are predominantly bile salts and calcium cholesterol in a small quantity. They may be small, brittle, black, and spiculated. This occurs due to the supersaturation of calcium bilirubinate carbonate, and phosphate, commonly secondary to hemolytic disorders and cirrhosis. There are stones which are usually 1 cm and less, which is brownish yellow in color, and soft and mushy, and they occur in the gallbladder or the bile duct secondary to infection caused by bile stasis. Here you see the varieties of stones: single, double, triple, and multiple, and in varied colors. Risk factors for gallstones are age above 50 years, females, people on estrogen replacement therapy, obesity, family history of gallstones, diabetes mellitus, pregnancy, high fat and high cholesterol diet, Crohn's disease, lack of exercise, increased triglyceride levels, total parenteral nutrition, and patients who have undergone gastric bypass. Majority of the patients with gallstones have no symptoms at all. These stones are called silent stones. Majority of the asymptomatic patients remain asymptomatic for long periods of time. Asymptomatic patients may be treated expectantly without any treatment by observing them till symptoms develop. The risk of developing gallstones related symptoms are rare, and there is no advantage of prophylactic cholecystectomy, but once symptoms develop, cholecystectomy should be done at the earliest. Gallstones present in various forms. The most common presentation being the chronic recurrent upper abdominal pain, probably due to mild infection. This condition is called chronic calculous cholecystitis. There are no clinical signs associated with this condition. The second type of presentation of gallstones, which is less common, is acute severe right upper abdominal pain with radiation to the right shoulder or to the right scapular region, may be associated with vomiting and mild fever. The clinical sign associated with acute cholecystitis is tenderness in the right hypochondrium on deep inspiration. This sign is called Murphy's sign, which was described by John Benjamin Murphy. What happens to the gallstones in the gallbladder? Majority of the times, the gallstones stay quiet inside the gallbladder, especially when they are heavy. When there are small stones, they float in the bile and jump into the cystic duct and block. Some stone can go into this common bile duct and block the common bile duct to create obstructive jaundice. A stone can go further down at the confluence of the common bile duct and the pancreatic duct and create pancreatitis. As told earlier, a small stone is mobile in the bile and migrate to the cystic duct. When it reaches the cystic duct, it causes an acute obstruction of the cystic duct, causing distension of the gallbladder, and the bile can be replaced by mucus, a condition called mucocele or hydrops. The mucus can get replaced by pus, a condition called empyema. When the gallbladder distension becomes more and more, it may lead to gangrene and perforation. The perforation of the gallbladder can result into three situations. 1. Localized collection of bile or pus around the gallbladder, causing a localized peritonitis or pericholecystic abscess. 2. A large collection can spill into the peritoneal cavity, creating a generalized peritonitis. 3. The perforation can happen into an adjacent organ to cause cholecystoenteric fistula, and the migrating stone can cause obstruction of the stomach, causing vomiting of gallstones. When it obstructs the pylorus, it is called Bourette syndrome. When it obstructs the small bowel, a gallstone ileus happens, where the patient presents with intestinal colic and obstruction of the small bowel. A large bowel entry causes diarrhea provoked by the entry of bile salts into the colon. The third set of symptoms are associated with high-grade fever. The high-grade fever is caused by conditions like empyema of the gallbladder, gangrenous cholecystitis, and cholangitis due to obstruction of the common bile duct. The obstruction of the common bile duct can be caused by an intraductal stone or an extraductal stone by a stone in the cystic duct, which is called the Mersey's syndrome. The condition ascending cholangitis is generally associated with high-grade fever and jaundice. The fourth set of symptoms of gallstones mimic other disorders like acid peptic disease, GERD, upper abdominal dyspepsia, right lung and pleural inflammations, myocardial ischemia. What is the differential diagnosis of acute cholecystitis? Duodenal ulcer perforation, acute right pyelonephritis, right basal pleurisy, myocardial infarction, herpes zoster of the intercostal nerve, and acute appendicitis. How do we investigate a patient with cholecystitis? The first investigation would be a transabdominal ultrasound, which has an accuracy rate of about 95 to 98% in demonstrating gallstones. Endoscopic ultrasound is also a better investigation and is able to detect even small stones, that is 3 millimeters or less, missed by transabdominal ultrasound. MRI has an accuracy rate of about 95%. CT may be required rarely. Plain X-rays may be contributory only when the stones are radiopaque. Isotope scan, the HIDA scan, technetium labeled analog of immunodiacetic acid scan with gallbladder stimulation with fat or intravenous administration of cholecystokinin can be used to calculate the ejection fraction. The ejection fraction below 35 degrees is considered abnormal. This investigation is useful in acalculous cholecystitis. What is the treatment of acute cholecystitis? Acute cholecystitis is treated conservatively by nil by mouth, intravenous fluids with antibiotics and analgesics, followed by a cholecystectomy at a later date by laparoscopic or open procedure. Cholecystectomy may be immediately done within 24 to 48 hours or delayed after 6 weeks, as both procedures have similar success rates, complications, and conversion to open procedure. Subtotal cholecystectomy is performed rarely today when there is severe inflammation. The treatment for chronic cholecystitis is elective cholecystectomy, either laparoscopically or by open procedure. Today, the laparoscopic procedure for cholecystectomy is gold standard. Now we come to choledocholitheasis. Choledocholitheasis is defined as stones within the common bile duct, which are usually formed in the gallbladder and pass on to the common bile duct. Primary common bile duct stones are also possible. Stones in the common bile duct may produce obstructive jaundice, but in a patient without jaundice, it is difficult to diagnose clinically. When the obstructed bile gets infected and causes high fever, the condition turns grave and needs emergency management. When the stone obstructs the pancreatic duct also, the situation is still more grave as acute pancreatitis may supervene. The obstructive jaundice caused by a CBD stone is always painful. There are two varieties of jaundice produced by an obstructed choledochous stone. One is an intermittent painful jaundice due to the bile-valve action of the stone, and secondly, a progressive jaundice by an impacted stone. The obstructive jaundice is diagnosed by increased levels of serum bilirubin. The total and the direct types are increased. Serum alkaline phosphatase show high levels. Serum amylase and lipase show high levels when there is acute pancreatitis. In urine examination, the bile salts and bile pigments are present, whereas urobilinogen is absent. Radiology is the mainstay of investigations of patients with obstructive jaundice. The first investigation would be an ultrasonogram. The transabdominal ultrasonogram has a detection rate of about 70 to 80% of detecting dilated bile ducts, the high rate of jaundice patients, but only 25% accurate in detecting the CBD stones. The endoscopic ultrasound has an accuracy rate of about 95%. MRCP has the accuracy rate similar to endoscopic ultrasound, and most of the stones missed by MRCP are less than 6 millimeters in diameter. CT cholangiography has the accuracy rate less than that of either EUS or the MRCP. ERCP is accurate in more than 90% of patients, but should be performed only as a preliminary therapeutic procedure, as complications like acute pancreatitis, bleeding and perforation may occur. When there are stones in the gallbladder and also in the common bile duct, the priority of treatment goes to the common bile duct stone. The CBD stone has to be extracted first, followed by cholecystectomy. The treatment for a CBD stone is an endoscopic procedure. ERCP sphincterotomy and basketing or balloon extraction is used for removal of obstructing gallstones in the CBD. A large impacted stone, which cannot be extracted by an ERCP procedure, can be broken by an endoscopic lithotripsy or an extracorporeal lithotripsy and follow it up with an ERCP and stone retrieval. The second option would be to perform a spyglass cholangioscopy and shatter the large stones and extract them. The surgical procedure to remove a CBD stone would be to do a laparoscopic or an open choledochotomy. Open CBD exploration to remove a CBD stone is rarely performed today. When there are multiple stones and the surgeon is not definite that they have removed all the stones, and there is a grossly dilated CBD, the dilated CBD can be anastomosed to the duodenum, procedure called choledochoduodenostomy, by a laparoscopic or an open method. Here you see the flowchart for the management of choledocholithiasis. When the CBD stones are asymptomatic, the dilemma comes as to what should be done. But prophylactic ERCP and stone extraction is done only in select situations. When the stones present in an acute fashion with acute right upper quadrant pain, with tenderness and jaundice, a single stone, if it is extractable, has to be extracted by an ERCP procedure. When the stone is impacted or large in size, it has to be broken down by lithotripsy and follow it up with ERCP and stone extraction. When there are multiple stones, they can be extracted by balloon catheter. Laparoscopic or open choledocolithotomy may be required very rarely when the endoscopic procedures fail. The concluding treatment for gallstone disease is laparoscopic or open cholecystectomy. Laparoscopic cholecystectomy is the gold standard today. There are some take-home messages in gallstones. Asymptomatic stones in the gallbladder, by and large, do not require any treatment, excepting in patients with comorbidity. There is no medical management to dissolve stones and should not be crushed and wait for their spontaneous expulsion, as in renal stones. While investigating for upper abdominal dyspepsia, please add ultrasonography of entire abdomen in addition to upper GI endoscopy to detect the stones. The take-home messages regarding symptomatic gallstones. One symptomatic, patients with gallstones need elective cholecystectomy. Acute calculous cholecystitis is treated conservatively with elective cholecystectomy or emergency cholecystectomy as per the situation and experience of the surgeon. Today, laparoscopic removal of gallbladder is gold standard. Good and knowledgeable surgeons should not hesitate to convert laparoscopic procedure into an open procedure if needed. The take-home messages regarding the CBD stones. All stones in the CBD require endoscopic removal, followed by cholecystectomy, even if the gallbladder is empty. All patients with CBD stones with high fever and jaundice, with or without the features of acute pancreatitis, require emergency removal of obstructing stone along with cholecystectomy. Thank you very much for watching.